Thank you. Good afternoon, ladies and gentlemen, and chairman, and thank you for the invitation to be here. So my task is to discuss esophageal and gastroesophageal junction cancers and try and differentiate them, and I'll focus mainly on the endoscopic aspects of these cancers. So if you see what's happening to the epidemiology of esophageal cancers and cardiac cancers or GE junction cancers in the world, the majority of the squamous cell cancers, at least in the West, are decreasing in incidence. And during the same time period, esophageal adenocarcinoma and GE junction adenocarcinoma are increasing in incidence. So this is the changing phenomenon that we see in most of the Western world. Squamous cell cancer, and as endoscopists, we want to diagnose them early so that we can treat them, are multifocal in nature and can be very subtle as shown on this endoscopic image. And we do need enhancement by the use of dyes such as Lugol's iodine, which is shown here, showing that this is really a multifocal squamous cell cancer, and this is very typical of squamous cell cancer of the esophagus. How do we do this endoscopically? Here's that same patient, and once we see a subtle lesion, what we want to try to figure out is, are there other lesions which also need either biopsy or endoscopic therapy? And you can see all these unstained areas by Lugol's iodine here, and the main lesion is right there in the center, but there are all these satellite lesions surrounding the main squamous cell cancer of the esophagus, and this becomes extremely important to determine what the extent of the cancer is, either for endoscopic therapy or for radiation therapy to mark the fields as to what's the proximal and distal extent of the squamous cell cancer. Now, if we switch to adenocarcinoma, these are from the distal esophagus or the gastroesophageal junction. And if you look at esophageal adenocarcinoma, these are the risk factors for it: Barrett's esophagus, reflux symptoms, and has been linked with the increasing incidence of obesity. And if you look at gastric cancers, these are the non-cardia, the non-GE junction cancers. These are related to H. pylori infection, which again is decreasing in prevalence, and to atrophic gastritis. And then you're left with these cancers which straddle both the distal esophagus as well as the proximal stomach, which are the junction cancers, and they tend to have a little bit of features of both, although they behave primarily as distal esophageal adenocarcinomas. And these cancers are diagnosed when we do a close retroflexion in the gastric cardia, and that's an important part of a maneuver that we do in patients in which they are high risk for these cancers, because some of these subtle cancers can be missed. And so this is a pure GE junction cancer right at the gastric cardia seen on retroflexion of the endoscope. The challenges that we face when we look at adenocarcinomas are that the ICD-9 codes use the term interchangeably of what's cardiac cancers and GE junction cancers. And endoscopically, we do not have a good definition of what the gastric cardia is, and therefore the potential bias for misclassification of GE junction cancers always exists, whether it is a proximal stomach cancer or is this a gastroesophageal junction cancers. And if you go back in time, we really don't have good data before the 80s because a distinction between junction cancers and distal cancers of the stomach were not made. Also, the literature has variable definitions, at least endoscopically and in the GI literature. is a cancer of the GE junction is defined as that which includes the distal third of the esophagus or the proximal stomach, which is the cardia. And others have widely used this definition, which is that any cancer which goes across the anatomic GE junction is defined as a gastroesophageal junction cancer. However, what I'd urge everybody to do is to use the Sievert classification, which is probably the most well-validated and widely used classification system for adenocarcinomas in this area. You can use type 1, which is the distal esophagus, just above the gastroesophageal junction. And the majority of these are related to Barrett's esophagus. Type 2 is that of the true gastric cardia, and this is just immediately above or below the gastroesophageal junction. And finally, then you have the subcardial cancers, which are greater than 2 centimeters below the anatomic gastroesophageal junction, and these would probably behave more like the non-cardia gastric cancers. So endoscopically, how do we deal with this? We use the top of the gastric folds to define the GE junction or the EG junction, and anything above it is the esophagus, and anything below this landmark is the gastric cardia. And so you can see that it's a very arbitrary landmark that we use, and even a few centimeters or millimeters up and down can change this definition. So there are some subtle variabilities in making this diagnosis. Then we come to the issue about what's the precursor lesion. For the majority of the GE junction cancers, it's related to Barrett's esophagus and GERD, but in a subgroup, it could be related to gastric intestinal metaplasia, which arises from Helicobacter pylori infection. And this is endoscopically how we look at it. The patient on the top has reflux symptoms, has endoscopic columnar-lined esophagus, which is Barrett's esophagus, and the patient down below has no reflux symptoms, has symptoms of dyspepsia, was found to have a gastric ulcer, and has a normal Z-line. And if biopsies are obtained from these areas, you will find intestinal metaplasia. So we do know that intestinal metaplasia is the precursor lesion to both these conditions, but again, it's endoscopically that we make this diagnosis of whether somebody has just GE junction intestinal metaplasia with or without Barrett's esophagus, and that becomes important for surveillance, screening, etc., maybe not for endoscopic treatment or for oncological treatment in this situation. Once we have Barrett's esophagus, which Raf would be talking about, we use the Prague CNM criteria to grade it, in which we endoscopically measure the circumferential extent of Barrett's esophagus or this columnar-lined esophagus, and then we use the most proximal extent, which is the M extent, and endoscopically this patient would be labeled as having a C2 M5 Barrett's esophagus. And if there's a cancer within this, we would label this as a patient who has either a T1, T2, T3 cancer within a Barrett's esophagus, which extends with a C value of X and an M value of Y, which gives us an idea as to what the total length of Barrett's esophagus is. And this becomes important, as Dr. Bishops will talk about the endoscopic treatment, is because in Barrett's we'd like to endoscopically remove or eradicate the entire segment, whereas if it's a pure cardiac cancer without any Barrett's, you would be fine just treating just the area of cancer and will not have to endoscopically treat any of the esophageal mucosa, and therefore some of these subtle changes or variations in adenocarcinomas of the GE junction versus Barrett's esophagus are important. Now, based on the Sievert classification, if you look at the epidemiology of distal cardia and the subcardia cancers, what you find that the average age is very similar. However, as you move more close to the esophagus, it has a more male predominance. And again, it has more association with Barrett's metaplasia as you move to the distal esophagus as compared to moving closer to the distal stomach. And so it tells you about what the epidemiology of these cancers are. And again, as opposed to squamous cell cancer of the esophagus that we all know are definitely related to ethnicity of blacks as well as in Hispanics, adenocarcinomas are more common in the Caucasian race and are related to reflux symptoms, obesity, and there is some association with smoking and not with alcohol, whereas for squamous cell cancer of the esophagus, as we're all aware, it is a cancer directly related to smoking as well as alcohol. So if we look at clinical recognition of junction cancers, on histology, these could be diffuse or intestinal. If it's diffuse, it's probably gastric cancer. If it's intestinal, close to the G junction, it could be either behave as distal esophageal cancer, and if it's H. pylori, it's probably distal gastric cancer and behaves as that, whereas if the patient has reflux symptoms or has Barrett's esophagus, these behave more like distal esophageal adenocarcinomas. So G junction cancers predominantly behave like distal esophageal cancers, but in a subgroup of patients could behave as non-cardia or distal gastric cancers. So just a brief example of what we would see this endoscopically as, again, an example of a patient with junctional adenocarcinoma. And again, what you will be seeing here is a retroflexion in the stomach, and this is an area of abnormality, which is seen right there. A very subtle cancer. This was mucosal or T1A esophageal adenocarcinoma. And we are using a high-definition endoscope looking at this lesion very carefully. We have the ability to switch, in this case, to blue light, which is electronic chromoendoscopy, which gives us the ability to look at the mucosal and vascular patterns and identify the extent of this cancer. Next, we, in this situation, ended up resecting this cancer. And what this allows you to do is look at the lateral and the deep margins and allows you to determine whether you've resected this cancer. And again, we'll hear more about this, but just this is an example of a junctional adenocarcinoma which is being resected endoscopically and shows you that how an R0 resection in this situation is important, which will determine whether this patient needs any further chemotherapy or not, and whether the nodes were positive or not will also determine that. So if you look at just some data on using mucosal resection for squamous cell cancer, and I'll just focus on that because the next speaker will talk about adenocarcinomas, and the majority of this data for squamous cell comes from Japan, where cancer of squamous cell cancer of the esophagus is more common. And when you see that if you do a piecemeal resection of these lesions, recurrences can happen. And if you have multiple lesions, like the first endoscopic images I showed you, there is up to a 40% chance of recurrence within the first 3 to 5 years of endoscopic therapy. So if patients do elect in squamous cell cancer of the esophagus to undergo endoscopic therapy, and there are multiple lesions, which is common for esophageal squamous cell cancer, recurrences can happen in up to about a third of these patients, and more so in those with multiple as compared to solitary lesions. More recently, these patients are now being treated with endoscopic submucosal dissection, which is a way of removing the entire lesion rather than doing it in piecemeal. And en-bloc resection with this is possible in virtually all of the tumors, especially if the lesion is relatively smaller, less than 5 centimeters, and an R0 resection can be obtained, which is important to know to determine what further therapy, if any, is needed for these. And this can be accomplished using or having very few complications. If you do circumferential resection, strictures can happen, and these can also be treated endoscopically in this situation. So again, just a snapshot of what endoscopically we can deal with squamous cell cancers of the esophagus. Now, finally, if you look at the clinical significance, does it really matter? I mean, for patient treatment, we approach these endoscopically very similar. The subtle differences are that if there is multifocal squamous cell cancer, we want to ablate or resect the entire squamous cell cancer and not just the primary lesion. In GE junction cancer, if there is no Barrett's esophagus, we resect just the cancer and there's nothing else to treat. But if there is Barrett's esophagus, we do end up treating it. As far as chemoradiation is concerned, there are some subtle differences, but for the majority of these cancers, they're treated very similarly. But I think if we pay attention to more problems with these cancers, such as if we want to develop preventative strategies for squamous cell cancer of the esophagus versus esophageal adenocarcinoma, they will be definitely different. The screening criteria may be different. Specific therapies, as I talked about endoscopically, are different. And then surveillance endoscopy for GE junction adenocarcinoma without and with Barrett's esophagus are also handled differently. So there are some minor differences in how we will clinically evaluate and treat these patients. So finally, to conclude, ladies and gentlemen, I think it's important that these differences between squamous cell cancer of the esophagus, esophageal adenocarcinoma, and GE junction cancers are made. And as endoscopists, we are the ones making these diagnoses. Examination that we do under retroflexion, and for those of you performing endoscopy, is key. Spending adequate time and having a clear view is important, and using some advanced imaging techniques if you have in a high-risk population will allow you to examine the area of the distal esophagus and GE junction carefully. Many of these neoplasias that we are dealing with are presenting as very subtle lesions like the one that I showed you, and so if careful examination and attention is not paid, some of these lesions could be missed. And early recognition and appropriate classification of neoplasia in the esophagus and GE junction will definitely lead to better patient outcomes. Thank you very much for your attention.